Imagine this. You find a lump in your breast or under your arm and panic sets in. You call your doctor and you anxiously await an appointment. Your doctor does the exam and he makes an appointment for imaging. Just adds to the torture waiting for each appointment to happen to figure out what's going on. Now imagine a different scenario. You're doing your imaging twice a year. You started that imaging early because you know you're at increased risk for breast cancer. One of those imagings finds a mass. It's found it before you could ever feel it. Now you're awaiting your biopsy and you know you're in control. You're actually 5 steps ahead of the game. Do you have a high risk for breast cancer? If so, starting imaging early and doing it more frequently can be life-saving. But how do you know if you have a high risk? Should you stick with the standard imaging or should you do it more frequently? Politicians talk all the time about precision medicine, but what does that really mean for you? How can you customize your health decisions to your unique needs? This is more than just about your physical health. Knowledge gives options. Options give control. And control tends to relieve anxiety and increase strength and resilience. By learning your options, you're taking your first step towards empowerment. So let's dive deeper and learn more about your options here. So the first thing you need to know is, what does it mean to have a high risk for breast cancer? Now, generally, the guidelines basically say if you have about a 20 to 25% lifetime risk for breast cancer, you're considered high risk. The reason is average risk, 1 in 8 women, about 12.5%, get breast cancer, regardless of family history, regardless of other risk factors. So if we know who's in that 20% risk range or higher, we can offer some extra options. And there are actually multiple organizations that adjust the screening recommendations, everything from American Cancer Society, the National Comprehensive Cancer Network, the American College of Radiologists, American Society of Breast Surgeons, all tailor their recommendations for breast screening based on where your risk falls. Most of these recommendations that we use from these organizations are what we use here in the United States. If you're from a different part of the world, there may be different guidelines that they use in different places. So I am focused mostly on what we're doing here in the US. Canada is similar, UK is similar. But why start screening early? You know, if you're at average risk for breast cancer, average age of diagnosis tends to be later, tends to be around 60 years old. So starting mammograms at 40 or 50, depending on what guideline you're going by, does pick up the vast majority of those sporadic breast cancers. However, if you have a higher risk, that can push the age younger when you tend to see those breast cancers. If we're seeing it at a younger age in your family, or we just know you have a higher risk because there is maybe a little cluster of breast cancer in your family, we do recommend starting that screening earlier. In addition to starting earlier, we actually recommend doing 2 different screens each year. The mammogram is the standard one that we tend to offer to all women. We still recommend a mammogram once a year. The earliest we tend to recommend that is around age 30, depending on what guideline you look at for high-risk women. But the second screen is a breast MRI. And breast MRIs actually can pick up some things that mammogram can miss, and vice versa. So it does increase overall detection. So that does help when we know someone has a higher risk, pick things up as early as we can. Another recommendation is to do 1 to 2 clinical encounters or clinical breast exams per year. So that means having a regular visit with your doctor once or twice a year. It could be twice. And getting a breast exam at those visits at least once a year, maybe twice a year. And the idea there is, if anything's ever felt between imaging, get it checked out. There are some limitations here. Any imaging technology can flag benign things. And when we feel lumps, it's not always something cancerous. There's a lot of benign things out there. And the more we're checking, of course, the higher chance we'll find some benign things as well. But the balance there is, if we're at higher risk for breast cancer, we obviously want to catch that early if it's going to happen. So we are trying to balance out the overcalls or callbacks for benign findings with the early detection. So that balance we push a little bit more towards, let's check more frequently for earlier detection for women who have higher risk. But it is something you have to keep in mind with what you're deciding to do. Okay, so how do you even know if you're at higher risk for breast cancer? There are actually a number of different models that can estimate the risk. Some of them take more information into account than others. So what I'm going to do is I'm going to go through a list of those models. Some you do have access to free versions online. Some of them you only have access to if you go through a provider. But let's get into a little bit of what each one tends to look at, which ones are the better ones to use for determining screening recommendations. The Klaus model was developed to look at family history, how many people in the family have had breast cancer and the age of the woman. So also looking at how many years left they may have in their lifetime. So taking the age of the woman, where they're starting, taking into account their family history, we can kind of gauge a little bit of what is their lifetime risk for breast cancer. Now, when I quote lifetime risk, by the way, obviously I have no crystal ball. I can't predict how long each individual is going to live. So many of these models define lifetime risk as risk to age like 80 or 85. It depends on the model. So the closer you get to that age, fewer years are in that window, your total risk for breast cancer actually goes down the longer you go without a breast cancer. Now, each year's risk will go up with age, but the total risk altogether goes down because there's fewer years we're adding up, basically. Another model that's often used is what they call BRCA Pro. Now, BRCA Pro does take a little more into account with the family history. They take into account, yes, who's had breast cancer, ovarian cancer as well in the family because of some of these genes that could overlap both. They also take into account a few personal risk factors. Things like when we get our first period, go through menopause, factors along those lines they can take into account as well. This model also takes into account if you've had a BRCA mutation identified or if you had testing that was negative. It'll take into account if there's a mutation in the family that you're negative for and those types of things as well. So it takes a little more into account. So it's probably going to be a little better estimation, especially if there's mutations known in the family. Now, the third model I'll talk about includes even a little more information. This model is called the Tyrer-Cuzick model. And this model is the one that I tend to use most frequently. It takes into account extended family, all the way through grandparents, out through cousins. In fact, it'll take into account how many people have not had cancer and balance that out, how long they've lived without a cancer. It'll take into account a whole variety of personal risk factors, including height and weight, when you got your period or went through menopause, if you have kids, what age you had your first, whether you've had breast biopsies that showed some changes that might change your risk for breast cancer, atypical hyperplasia or usual hyperplasia. It'll take into account breast density in the most recent versions of this model. Just a little footnote there, premenopausal women tend to have more dense breast tissue. There's a sliding scale that they use, a ranking system. So if they say you have dense breast tissue, the question is how dense? Is it heterogeneously dense? Is it extremely dense? What terms are they using? The more dense tissue they see, it can bump the breast cancer risk slightly. So this model does take that into account as well. Another model that takes into account even more information is Bodicea, or sometimes called CAN-RISK. Now, CAN-RISK is the most up-to-date one. Takes into account, again, family history. Again, how many people have not had cancer. Takes into account carrying mutations in BRCA genes, which, by the way, Tyrer-Cuzick takes that into account as well, or those who have not. But Bodicea also takes into account people who have moderate risk mutations, or if it's in the family and you don't carry it, how does that impact your risk? So it does take into account more than just BRCA1 or 2. There are other genes that can play a role in breast cancer risk at different levels of risk. It takes into account ovarian cancer in the family as well because of the overlap with some of these genes, and a lot of personal risk factors. Everything from the hormone-based factors, how long our ovaries are active, when we had our first child. It takes into account hormone replacement therapy, birth control, whether you've had breast biopsies, breast density, it actually is probably the most thorough of the models. So this model is a little bit more cumbersome to run, but if you get a chance, especially if there's a moderate risk gene in the family, this is probably the best model to run because it's the only one that takes those into account. So these first 4 models are all models that can be used to determine your risk level and be used for those guidelines for offering extra breast screening. Especially NCCN basically lists the BRCA Pro, the Tyrer-Cuzick, and CAN-RISK as models that should be used to determine lifetime risk and determine that extra breast screening recommendation. There is one model out there that is not recommended to use for this, and it is something called GALE, or is also on the National Cancer Institute website, NCI, and it was primarily developed to try to determine who to offer a risk reducing strategy. It was used in a study looking at using tamoxifen, raloxifene, some of these medications that block the hormone pathways to try to see how much it reduces the risk for breast cancer. And they were really only looking at 5-year risks with this model. But they've extended it to look at lifetime risk. The problem is this model really only takes into account first-degree family members who've had breast cancer. It does take into account few other personal risk factors, mainly biopsy-related things. The problem is it doesn't go beyond parents and siblings when it looks at breast cancer, and it doesn't take into account how many people have not had breast cancer. It basically can miss the whole father side because men are much less likely to get breast cancer. They can, it just happens a lot less frequently. But if on dad's side there's aunts or grandparents with breast cancer, that model's going to completely miss it. And yes, it can still impact the risk for you to get breast cancer if there's breast cancer on dad's side. So it is really better to use the models that will look beyond parents as far as risk determination. Now, another thing about these models is they do keep updating them with new studies, new information, adjusting, what pieces of information are taken into account and how much they weigh them. For instance, Tyrer-Cuzick in the last couple versions added the breast density to their calculations, whereas prior to that, they did not use that. None of the models did initially. It is worth being on top of how these changes might impact what you should be doing. Now, that's a little tough to do if you're not seeing a breast specialist all the time. Most generalists may not even know these models or where they find them, how to use them necessarily. Some may, but many will refer to a genetic counselor or high-risk breast center to determine whether their patient needs that extra screening or not. Even breast surgeons sometimes will be running those models for people. How do you stay on top of this if you don't have regular access? And I'll just throw a plug in here. I do have a newsletter that I try to get out weekly to give updated information on breast screenings, high risk, other screens as well for other cancer types, what the guidelines suggest we should be doing, as well as some stories from my experience or my patient's experience with these screens and such. So if you'd like to stay on top of the new emerging data, feel free to subscribe to that newsletter. It's completely free and we'll send you updated emails at most once a week. But of course, the most important thing is to make informed decisions. So go ask your doctor if you have a referral to a genetic counselor, high-risk center, or whoever in your area is available to run those risks for you and make those recommendations. If you don't have anyone local, there is another option. You can go to www.findageneticcounselor.com to either find someone local in your area who can provide those services for you, or by connecting you to a video or telephone service company that does that for you. And some big institutions do video visits anywhere within their state, so that can sometimes be an option if you're not nearby. So check that out. I will put all that information in the description below, and we will get into more detail on these imaging technologies in future videos. So please subscribe if you want to stay up to date with that. And I'll link a playlist here at the end that will list all our breast related videos if that's the topic you're most interested in. We will see you with the next one.